No,
that's a
because
whole
we
different talk.
discussed it all, I just wanted an extreme situation to be asked.
It's an
On to
extreme.
you. I would, Shreyash would be showing challenging case scenarios. We are running short of time. I would take your question in the end. And Shreyash, again, as a young, dynamic surgeon, consultant cataract and refractive surgery from Eye Foundation group of hospitals. And I'm sure he's going to come up with very interesting set of cases to discuss. On to you, Shreyash.
So I have just some cases to discuss, and I was supposed to go in the end if there was time left, but since a couple of speakers came late, I got the chance to present. So I'll quickly run through some cases, would like the inputs of all our panelists and audience here. So first, this was a patient where this is a case of smile, where I had a suction loss. Everything was going well. This patient seemed fairly cooperative, was normally, this is the point you lose suction, but everything was fine. But suddenly at this point of time, the patient moved and the suction was lost. But I actually thought the suction was gone. But in fact, it was not, the suction was not gone. The suction had, there was immediately, because there was a sudden jerky movement, and immediately the suction was applied again, but it was a pseudo suction. I mean, the limbus and conjunctiva had gone into it, and there was a pseudo suction. And because there was only 2 seconds left on the laser, the side cut happened, because I had not taken my foot off the pedal, thinking it was a suction loss. So this treatment was completed, and as you can see here, this is where the secondary this thing has happened. So I thought, I was not very sure what I should be doing at this point of time. I thought I'll treat the other eye, come back and think about what I need to do here. So I went ahead, and the second eye, I think I was a little more cautious of the fact that this could happen, and the patient, I don't know, for some reason, had almost an exact suction loss at the very same time. But fortunately, at this point of time, when this suddenly happened, I took my foot off the pedal. So I was able to go ahead and just make the incision cut. Mind you, during this incision cut, it's important that you get correct centration, but you have now a full ring available. So you can just center it on the ring which is already there. Even if you're not able to visualize the pupil, the ring is very much visible. So it was very easy, went ahead and did this. So now for the second eye, I was thinking now that since the lenticule is already made, maybe I'll do a circle and then take out the lenticule, because the lenticule had been formed fully. But instead of that, what I thought is, if I, instead of creating a flap, I used the circle software, but created a very large hinge, 270-degree hinge, and just made, 300-degree hinge, and made a 40 to 60-degree side cut superiorly, and accessed it and went ahead and then completed the dissection to do it. So just an example of circle being used as an escape option, if at all you do this, encounter this situation, and the lenticule can be removed. The post-op looks, the day 1 post-op looked like a smile patient. It didn't really look like what a LASIK patient would have been. So the learning points from this case for me was to definitely take the foot off your pedal as soon as you see any instability in your suction, and that's something which we should do. I think the first case I was caught unawares, thinking that in the next 2 seconds the procedure will be over. Ensuring proper centration on redock is very important for your refractive outcome, as well as, if your cap cut, lenticule cut doesn't overlap perfectly, then you may have a small bit of lenticule which gets left behind, and you'll not get a perfect circular lenticule, and that can also induce a little bit of irregular astigmatism and can use circle as an escape route. Any thoughts from panelists? Anything else you would have done differently?
I've had this situation where where the axis incision has not happened. I think 2 occasions. One, the patient was belling and then had a suction loss, and the laser actually said the treatment is completed, but the axis incision was not there. The other is when I had a conjunctival prolapse, which kind of blocked the axis incision from happening. So everything was okay except the axis incision. So what I do is I take my old RK knife, preset it, and make an incision, and then go in and then remove. I have videos. It works very well. I don't have to use another license, otherwise you lose a circle license, which is the same cost as a smile license.
True, sir.
Can you go on to your next?
So the next case is actually quite similar to what sir showed for hyperopia, and I just thought there were a couple of points which to discuss and how to manage this. So this was a patient with a +7 diopter hyperopia with a -2 diopter cylinder, and this is the preoperative topography. Unusually so, maybe because of the high cylinder, but the patient in both corneas had posterior steepening on both eyes. Although the amount of central ablation for such a high hyperopia is not going to be much, but considering the extent of regression, I was not too keen. The AC depth was only 1.6, so obviously any phakic IOL was impossible. So really the only options were either to do a clear lens extraction with multifocal IOL, but considering a very young patient, I was not too keen on doing it. So thought of doing a tissue additive procedure. So the steps are very similar to what Sir showed, in the sense we are using a LASIK flap but a very large hinge. This was a small eye, so even though I was taking only a 7.7 millimeter flap, the incision actually came at the limbus. And you can see that bleed there and this thing. Rest of it is quite similar. I'll move on to the other eye also because of paucity of time. One thing I realized is, I don't use any special instruments like what Sir showed. Maybe it's a good idea to use it. But if you use a Sinski, which is what I'm used to using for a DSEC surgery or other things for pushing in a lenticule, the gap here is lesser. It's not like the anterior chamber. So you can't really slide it out so easily. So using a flat instrument like the one which he showed, or using just an iris repositor is a better idea, so that you can push it in nicely. So you can see just a flat iris repositor, and then massaging the lenticule and ensuring that it is completely centered on the center of the pupil on the Purkinje image is useful. Although I did my best to center, if you look at the post-operative period, the refraction was good. The patient was happy. It was just the residual cylinder, and I had anyway told the patient that we'll be doing a PRK as a subsequent procedure for correcting the astigmatism. But the patient was quite happy, and we had matched the similar power as far as the SMILE lenticule was concerned, and this is the ASOCT showing that interface gap where the lenticule has been inserted, and both eyes you can see it. And it's almost very difficult to make out unless you do a dilated retroillumination. It's very difficult to even make out the lenticule. However, the centration is not absolutely perfect, as you look evidenced by the pachymetry map and the curvature maps. It definitely could have been a little better. So any tips on what we can do for centration, and as well as for hyperopic astigmatism, have you been able to correct astigmatism also using myopic astigmatism lenticules?
For hyperopic astigmatism, what you do is you correct the astigmatic component with SMILE. You have a little bit of sphere, like a 0.5 sphere, minus 0.5, and the cylindrical component, correct it using doing SMILE, and then you anyway have a pocket where you remove the lenticule, and then you put in the same optic zone lenticule so that it fits well, and that corrects the spherical error. That is something you can do. And for centration, what I do is you have the reticule on your right eyepiece with rings. Okay, so once this is normally a 6 millimeter or a 6.5, and you have a 6 millimeter ring there. The patient is fixating at the light at the center of the crosshairs, and then you use this circle to center to match the edge of the lenticule. When you put the ledge, and then you get a perfect centration. The other thing is you can mark the center with ink, but that again I don't like it because it's there post-op. It may interfere with the vision. But so if you just use the rings on the lenticule in your reticule in your right eyepiece, then you can match it perfectly.
The one which you showed, was it a preserved lenticule, sir, or was it a fresh lenticule?
It's a fresh lenticule. We first published with cryopreserved lenticules, but we found that the reaction is more with cryopreserved. So now we just use fresh lenticules because we have plenty of myopes undergoing SMILE.
The one which you showed, probably maybe it was a little while longer kept in saline or something, was a little edematous. It was very nice. The edges was very clearly visible. I did SMILE in a previous
that was a 9 diopter lenticule.
So
to correct
and one very important question, we have to go on to the next speaker, just not time. What is the lenticule thickness which you use for the correction? Like, how do you calculate?
No, I used a myopic lenticule with a half a diopter additional. I didn't use 2 diopters, sir.
Correct the back vertex. See, I do a cycloplegic refraction and use back vertex correction,
distance, yes.
And then it works well. Above 6 diopters, okay, what happens is the posterior changes are more than the anterior steepening, so and that's why it takes away from the correction. So once you do a Bowman's relaxing, then you can see the posterior change. It comes to the pre-op levels. This is beautiful. We have published it. It's there in the JRS, I think, last month's this thing. So by just doing a simple Bowman's relaxation with Barron's refine.